Good evening, everyone, and welcome. My name is Stephanie Thompson, and I'm the National Consumer Partnerships Manager at the National Mental Health Consumer Alliance. I have the privilege of emceeing today's webinar in our monthly series, Consumer-Led Conversations, hosted by us, the Alliance. I'd like to begin by acknowledging the traditional custodians of the many lands which we are connecting from today. I'm presenting from the lands of the Yagara and Turrbal people in Mianjin, also known as Brisbane. I'd like to pay my deepest respects to elders past and present and extend that respect to any and all Aboriginal and Torres Strait Islander peoples joining us today. This acknowledgement is not simply a formality, it is a recognition that sovereignty was never ceded. These always were and always will be Aboriginal and Torres Strait Islander lands. It is also a recognition that long before our mental health systems were built, First Nations peoples held systems of care, healing, and collective well-being. Systems grounded in kinship, in culture, in land, and in spirit. We are proud to honour our partnership with the Indigenous Australians Lived Experience Centre and the leadership of our First Nations board members. Their guidance ensures our work is not only informed by lived experience, but also cultural authority and in the principle of self-determination. I invite us all to hold in mind that true healing and justice in mental health must be built on truth-telling, cultural safety, and respect for our Indigenous ways of knowing, being, and doing. Knowledge that has cared for this land for more than 65,000 years and has been passed down through the longest living culture in the world. Today, we're bringing together the powerful insights from consumer advisory groups from New South Wales, Queensland, and the ACT, each shining a light on what needs to change in our mental health systems and how lived experience leadership can drive that change. We'll start with the New South Wales Consumer Advisory Group, who have been exploring what a fairer Medicare mental health plan could look like. The early findings highlight what many already know. The current system is not meeting people's needs. Consumers are calling for more accessible, trauma-informed, culturally responsive care, reduced financial stress, and more than a limited sessions available. Next, we will hear from the Queensland Consumer Advisory Group, and they will take us into the world of systems governance. Their work asks a crucial question. How can lived experience be embedded, not just in consultation, but in the actual structures and decision-making processes that shape national mental health policy? And finally, we will hear from the ACT Consumer Advisory Group, who are developing a proposal for peer worker facilitated relational support groups. Their focus is on addressing social isolation, a very complex, widespread issue that deeply affects consumer well-being. Across all three presentations, one message is clear. Lived experience is not optional, it is essential. When consumers lead, systems become more human, more inclusive, and more effective. If you have any questions throughout the presentations, please send them through via the QA function. We will have some time at the end for our panelists to answer. If any of the content this evening causes any distress, Ash Watson, our peer worker, will be available for the duration of this webinar and for 30 minutes after to provide support. Thank you for being here today, for listening and supporting this work. I'd like to introduce our first panelist representing the New South Wales CAG, Kylie Smith. She's a passionate lived experience advocate and a community engagement leader dedicated to ensuring the voices of people with lived and living experience of mental health challenges are heard, valued, and embedded in system reform.
Thanks so much for that warm welcome, Steph. We would like to also acknowledge the traditional custodians of the lands that we're all from. Tonight, I'm calling in from the Darug land, and I'd like to pay my respects to elders past, present, and emerging. We acknowledge that land was never ceded and was, is, and always will be Aboriginal land. We value your holistic management of country over the millennia and realise that Indigenous knowledge systems have much to teach us about how we thrive as a society. So a bit about being mental health consumers. Being mental health consumers is the independent New South Wales peak organisation speaking with and for people with lived and living experience of mental health issues and emotional distress. Being's primary focus is to ensure the voices of people with mental health issues, and emotional distress are at the forefront of all of the work that we do and heard by decision makers, service providers, and the community to lead and influence systemic change in services and in systems. My name's Kylie, and I'm the Lived Experience Engagement Manager at Being. And the incredible CAG that I get to work alongside are Ezra, Francine, Bridget, and Tia. And I'm joined here today with Ezra, Bridget, and Tia. It's important that we take a moment to also recognise lived experience. We honour and value all people with lived experience of mental health challenges, especially those from intersectional backgrounds whose voices continue to remind us that the system must work for everyone. We also acknowledge that those who have walked before us, whose advocacy, courage, and persistence have paved the way, and those who walk alongside us now, shaping the path forward. We stand with you in your strength, your courage, and your leadership as the driving force behind all that we do. Your voice has always mattered, and it always will. I'll now hand over to Bridget to talk about our project.
Thank you, Kylie. So what is our project? Our project is about the Medicare Mental Health Care Plan, a fairer Medicare, reshaping the Medicare Mental Health Care Plan. Currently, this initiative is for 10 subsidised visits to a psychologist in a calendar year, and we think this model is inadequate. We want a more inclusive and equitable Medicare mental health care plan. Our project aims to influence reforms that ensure the mental health care plan genuinely meets the diverse needs of all consumers, including those from marginalised, rural, remote, culturally diverse, LGBTQIA+, and lived experience communities who currently face barriers to access. We want increased accessibility to mental health supports. We seek changes that reduce financial, structural, and geographical barriers, ensuring people can access timely, affordable, and appropriate psychological and psychosocial supports without long wait lists or cost prohibitions. This project is about listening, learning, and working together to shape a mental health care plan that is practical, accessible, and genuinely fit for purpose. So who's leading this work? People with lived experiences leading this work, working for people with lived experience, guided by the principle nothing about us without us. This project is being led by people who understand the system firsthand. Our goal is to ensure that the voices of those most impacted are central to shaping solutions. So why is this project nationally significant? The current Medicare mental health care plan is failing many Australians. Across the country, people continue to report long wait lists, high out-of-pocket costs, limited session numbers, and difficulty accessing culturally safe or appropriate care. These issues are not isolated. They are consistently raised in every state and territory, making reform a national priority. We see that equity gaps exist across the entire country. People in rural, remote, and regional communities, culturally diverse communities, LGBTQIA+ communities, First Nations peoples, and those with complex or long-term mental health care needs consistently face greater barriers. National reform ensures that fairness is not postcode dependent. I will now hand you over to Tia, who will talk about how we are going to do this work.
Thank you, Bridget. To achieve this work, we have 4 key project phases. Phase 1 being co-design and development. From the very beginning, this project has been guided by the voices of lived experience. It started with people coming together, sharing their insights, their challenges, and what we know the system gets right and where it falls short. Together, we built the foundations of this work, developing a project plan that reflects what matters most and co-designing a national survey to make sure we were asking questions that truly resonate with people's real experiences. Being's 4 advisory committees, consisting of 42 mental health consumers, have helped shape and refine this work, with each voice bringing depth, diversity, honesty, and perspective. Phase 2 being national survey. We reached out to people across Australia to hear about their experiences with the current mental health plan. This involved finalising the survey and circulating it nationally to ensure as many voices as possible could be heard. The survey is currently still open and will close Friday the 10th of April. The third phase is data analysis and review. Once the responses come in, we will begin to analyse the data and stories shared and identify what is working, what isn't, and where the gaps lay. This process will ensure that the experiences of people accessing mental health support are at the heart of our project. The fourth phase is the final report. The final phase of our project will focus on bringing everything together into a report that highlights the key findings and shares key recommendations. What makes this report unique is that it will be shared through a lived experience lens, ensuring that the insights, perspective, and voices of people who access the mental health system are central. We've made meaningful progress in this work and are now nearing the end of phase 2. Over the past few months, we've been focused on listening, gathering insights through our national survey, with more than 250 people sharing their voices and experiences from across the country. As data collection continues, we're preparing to move into the next stage with data review beginning end of April. This is where we come together to really understand what people have told us, taking the time to reflect, analyse, and draw out the themes that will shape our recommendations. It is an important step ensuring that every voice shared with us helps guide the path forward. I'll now hand over to Ezra to go through some of our key findings so far.
Thanks so much for that, Tia. Hi, I'm Ezra. So at the beginning of March, we commenced that analysis of the preliminary findings from 273 survey participants and want to share some of those key metrics. Now, keep in mind, most of the questions were optional. So of the 211, 153 or 73% have been accessing a mental health care plan for more than 3 years. And of that group, nearly 2/3 have been using it for 6 to 10 years. So while the access itself technically doesn't expire, what this does tell us is that people are relying on this support long term, particularly in complex cases. And for many, that complexity doesn't exist in isolation. One of the more confronting, yet not unfortunately surprising findings was that around housing instability. So 46% of respondents reported experiencing homelessness and unstable housing at some point, and 5% said that they are currently experiencing it. And it's important to remember that in order to enroll in Medicare, you do need to have a valid postal address. What's also striking is that our findings closely align with the data that's on the Specialist Homelessness Services and the Australian Institute of Health and Welfare's websites. And housing's only part of the broader financial pressure that people are navigating. With the rising cost of living, we also looked at the financial stress caused by making gap payments. 74% of respondents reported moderate to severe financial stress. For some, that means carefully budgeting just to attend appointments, and for others, it means going into debt, using credit or borrowing money to afford care. And for 1 in 6 people, they're being forced to choose between paying for support or covering basic essentials like food, utilities, and, you guessed it, rent. Cost isn't just a pressure, it's a barrier. It's limiting people's choice, consistency, and their ability to stay engaged with the support that they need. When we asked how many sessions people need annually, a clear pattern emerged. Almost 3/4 says that they need more than 10 sessions, and 22% said that they would benefit from 30 or more. People aren't asking for short-term fixes. They're asking for consistent, ongoing support. Because right now, the limits in place don't match the reality of living with ongoing mental health needs. And we're already seeing this recognised in the NMHCA's own proposal for a national psychosocial support scheme. These findings highlight the need for flexible, adequate access to support that sustains long-term well-being. So, what does an inclusive, person-centered mental health care plan look like to you? Here's what some of our survey participants had to say. It would be great if there was more financial support and assistance with psychiatry appointments and access assessment appointments. Increase in sessions available, introduce alongside these sessions options to access trauma-informed holistic care, for example, yoga, art therapy, etc., and to reduce the gap fee. 10 sessions is absolutely inadequate, appalling actually. I need to keep on top of my bipolar. The mental health care plan is simply a band-aid solution. A heartfelt thank you to all of those 273 people that have already shared their voices through the survey. Your experiences, insights, and ideas are helping shape a mental health care plan that truly reflects the needs of our community. There is still time, as Tia did mention, to have your say, and no idea is too big because every voice matters. You can share your experience and contribute to the survey using the QR code that's on screen. And if you would rather get the link sent via email, you can email Kylie at the email address that's also listed on the screen there. Real change starts with listening to people's experiences and their visions for something better. Thank you.
Thank you so much, Kylie, Bridget, Tia, and Ezra. Like your presentation was so informative, and it really tells a compelling narrative about the long-term reliance on mental health care plans, the widespread financial stress due to gap fees, and there is a clear call for more choice, more sessions, more inclusive and culturally responsive care. And I think 273 survey responses is pretty big for something in our sector. So congratulations on that. Next, we will hear from the Queensland Consumer Advisory Group, who are examining how lived experience governance can be embedded into future national partnerships agreements. Our next panelist is Paula Arrow, who has worked in the social and community service sector for over 35 years and is a very passionate advocate for human rights. Paula identifies as having a lived experience of mental health, AOD, and suicide resulting from complex post-traumatic stress disorder. Thank you, Paula.
Thanks, Steph. Good afternoon, everybody. I'd like to echo the genuine respect and acknowledgement of Aboriginal and Torres Strait Islander people as First Australians. I'd also like to acknowledge any First Nations peoples attending today. So we thought we'd pick a nice, easy topic. So, we're going to take a look at how we can embed the lived experience, governance, stewardship, decision making in future national partnership agreements. I guess the reason we went big with this one is that there's a real window of opportunity, and I'll talk a little bit more about some of the Productivity Commission inquiry's findings, but our thinking is it's the sum is greater than the parts. If you've got a car where you've got good tires but not an engine that's not working, the windows roll up but they don't roll down, that car's not going to function very well. I do want to acknowledge, however, some pockets of brilliance around Australia where we have seen some really genuine co-design, co-production, and partnerships. And, we have come a long way with a little doodah. So, just setting the scene, I'd just firstly like to acknowledge Danny Williams-Brennan, who will be presenting with me today. She's the Director of Policy at the Mental Health Lived Experience Peak Queensland, which is our peak body that's been around since about 2022. Queensland, unfortunately, went for quite a long time without a peak body, and we really felt the impact, but Malik's really hitting the ground running. I'd also like it to shout out to the rest of our CAG members, who I'm sure are all online. So Isabel McGovern, Hannah Wilson, Nikki Walsh, Donna Allen, Catherine Haig, and who can forget our other co-chair, Kate Smith, who keeps us all in line. So we did start out with an EOI process, and we only started in October of this year. As many may know, these CAGs and state peak bodies are working with the National Mental Health Consumer Alliance to undertake these projects. And like I said, we've decided on system governance. So if we take a look at the Productivity Commission, which is an independent body that is brought in to take a look at a whole range of different functionings of government. We've had two inquiries into the mental health system, one in 2020 and then one just recently in 2025. And it's the 2025 was actually, they were not backwards in coming forwards and just saying that they were saying that the agreement is just not fit for purpose. So the national partnership agreement, the bilaterals have not been fit for purpose. In the 2020 inquiry, the focus was more on embedding participation within existing structures, but 5 years later, we need to dig a little bit deeper. And also the word co-design gets floated around, and I don't know. I'm sure many of you, like myself, will get invited to a co-design meeting or fill out a survey, and it's called co-design. We still, unfortunately, are not seeing genuine, authentic co-design, and we're still being exposed to tokenistic gestures in many cases. But again, acknowledging those that are doing great work out there. So what do we mean by system governance? So unlike organizational governance, which is running an organization and there's internal processes, things like this, the system governance is the whole ecosystem of for the mental health sector. So it includes things like clinical practice, financial management, risk management, cultural governance. And what we're proposing is to build on some great foundational work that's been undertaken around lived experience governance. I'll just hand you over to Danny.
Thanks, Paula. Well, I guess we have to ask the question, why have good systems governance in the first place? Well, at the moment, we have too many systems operating in a reactive fashion. So they wait for the harm to occur, then they react and try and provide solutions. What we want is to have lived experience partnerships and collaborations that will value add and ensure that it's actually proactive, looking to systems to stop the harm in the first place. If this happens, it will result in people-centered systems and program development, implementation, and evaluation. So 3 practical examples of participation in systems governance. There's one to do with lived experience governance framework and toolkits. Another one is the National Lived Experience Workforce Guidelines. And the third is the lived experience-led research and evidence base. In regards to the first two, they were not just co-designed, they were co-produced with the lived experience community and are really groundbreaking toolkits and guidelines in this area. in terms of the lived experience-led research and evidence base, we know that there's a lot of research out there. We know that it backs up what we're actually saying. I'll hand that back over to you, Paula.
Yep. So we're starting off with what is the problem, and look, this is by no way an exhaustive list at all. And I'm sure those of you that are around my age will also look at these and see things that we saw written 3 decades ago in terms of what was wrong with, what some of the problems were. Now, things like the inconsistency of lived experience influence into systems governance. It's amazing to see that Louise Burns' earlier research into barriers for, taking up lived experience in engagement and in the workforce. The number one barrier was dependent on if there was a commitment and culture by the executive. If that wasn't there, it was incredibly difficult to get really genuinely embed lived experience. No right to have a seat at the table, and even having a seat at the table. And I'm sure many of you out there that have been reps on committees sit there as the token lived experience person, and there's 20 odd service providers and government people around the table. That's no longer sufficient, and we need to think of other better ways of people being involved. And also, there's also that silencing of the lived experience voice. And I know myself, being a bit of a big mouth and saying it like I see it, that actually has shut doors, in terms of not being friendly and co-opted into the system and just letting the status quo go. Other areas, again, this I call them the C words. We at a systems level, we're still not truly seeing, real authentic co-design and partnerships occurring. The last national partnership agreement and bilateral agreements were largely done by governments. And no one really knew what they were about until they were launched. So we're hoping this time round, and at the recommendation from the Productivity Commission, to ensure that the lived experience is a part of that development of those agreements. Again, I think there's there's a sense that sometimes the mental health system forgets what they're actually here for, and it's actually for people with lived experience, not funded services or bureaucracies and those sorts of things. So we need to put the people right back into the centre of that. And we're also seeing, reduced capacity to achieve needs-based outcomes. And I won't even dare mention the N word or NDIS in terms of we're seeing now changes where they are trying to, in fact, do that. I think I've jumped the gun. I think this one's mine too. So some of our key insights is that, really, if we're really, really genuine about taking up these recommendations from the Productivity Commission, we need to be brave. We need to be looking outside of tradition. We need to really look at transformational change. And there are examples internationally where that people have, and then leaders and decision makers have taken that brave step of looking at the system and, reshaping, reforming to allow, partnerships and people that the system impacts on to be a part of. Need to elevate lived experience as a core governance principle. And I guess the one here, this resources and tools, about a decade ago, there was a certain bit that where the decision makers could get away with not doing some of these things that we're asking. But over this last 10 years, there's been an incredible wealth of resources, tools, guidelines that have been co-designed, co-led by people with a lived experience. So let's just get dust off these resources and guidelines and start moving towards implementation. Over to Danny.
Thanks, Paula.
Danny, there she is.
Yeah. So we've sort of touched on what is the evidence and credibility so far. We've got the history of the consumer movement and recommendations from decades ago still relevant. There's been lots of research, there's been campaigns, it's gone through the hands of different people, and we're still here knocking at the door saying we need systems governance. Of course, as Paula has said,
Sorry.
there are inquiries, the royal commissions, the recommendations. All these support the need for living experience governance. We know that if we have this lived experience governance in place, then there's going to be transparency and accountability for living experience in governance. And we know that transformational systemic change can actually come about. So,
Just sorry, Danny.
Paula.
You shouldn't have let me be the slide changer.
It's okay. Um, so what are the implications if we don't do anything? Well, if you keep doing the same thing over and over again, how can you expect there to be different results and outcomes? And that's basically where we're at. We can't just keep producing the same system, the same reactive system whereby harms are caused and we are trying to monitor and rectify those harms. We need to have greater living experience, participation in systems governance. Without this, the social determinants will continue to impact on people's mental health, and further community well-being will decline. We've also got to think of it from a resources funding point of view. And if you keep doing what we have been doing, you're still throwing money at a problem that has been created rather than throwing money to prevent the problem actually being created in the first place. So it just doesn't make sense to actually look at funding in that kind of terms. And you've also got to remember that at present, there's lots of silos between organisations, between service providers, and this will just continue. And there'll be a duplication of projects and programs if we do nothing. So basically, there'll be no transparency or accountability to community, and continued breaches of human rights will be on the table.
Thanks, Danny. So our call to action for this during 2026 is how lived and living experience can lead system change. Now, it's a huge topic, so we've obviously had to narrow it down to some of the key functions of system governance. And so we've decided on the 5 priority areas that we wanted to work on. So the design and strategic planning. So if we don't get that right, everything that rolls from that is going to be impacted. The monitoring and information sharing, and this is a really important one because there's so much data out there, but it's traveling up. We also need to have some data and information coming back to us about what's working and opportunities to input and contribute to that data. System learning, transformation, and innovation is the fourth area. And like I said earlier, we do have pockets of brilliance happening around the place. It can happen, it has happened, and we need to take a look at what and why, and unpack what and why and how that has worked. And standard setting, and just acknowledging the lived experience governance framework and toolkit. Um, Shout out to Ellie Hodges, who is the consultant on that, and the National Mental Health Consumer Carer Forum and the National PHN Mental Health Lived Experience Engagement Network, or Malene, who are now unfunded. We have our national peaks. Um, but a piece of work was actually done looking at all of the different standards that the system have to comply with. And through the project advisory group and the brilliance of Ellie's leadership, um, a lot of those standards, we already have ideas in those guidelines and tools about how we can strengthen those standards. And so our next steps, what happens next? So we've decided on working on a different topic each week, and having some really focused questions to unpack, and review, discuss, and then work out and make some decisions for recommendations going forward. We're not going to be able to solve all of the problems of the world, but we do hope that these series of briefing papers will provide some good concrete evidence base for our national and state and territory peaks in the development of policy, in their engagement and work with the mental health system. And we always have hope. So thank you everyone who's attended today. Thank you to the National Alliance for putting this on. It's great to be hearing what people like us out in the community think about things. So thank you. Oh, be quiet now.
Thank you so much, Paula and Danny. I think what your work has spotlighted so far is a critical truth that a lot of us in the lived experience movement and those who have come before us have known, is that without lived experience at the decision-making table, systems will continue to reproduce the same gaps and the same barriers, and unfortunately the same harm. So thank you for your work so far, and I'm looking forward to hearing the update later in the year. Next, we have the ACT Consumer Advisory Group, who are developing a proposal for a model of support for peer worker facilitated relational support groups. Our next panelist, Dia, is the ACT Mental Health Consumer Network's Policy and Participation Coordinator, and she was the lead researcher on the Access Denied project from 2022 to 2025. Dia is very passionate about accessibility and equity of the mental health care. Thank you, Dia.
Thank you very much for that, Stephanie, and good evening to everyone. So, first and foremost, I'd just like to acknowledge that I'm joining you this evening, both myself and Shilpa from Ngunnawal country, and would like to acknowledge that sovereignty has never been ceded and that these lands are and remain stolen land that always was and always will be Aboriginal land. So myself, my name is Dia Andrews, and I'm the ACT Mental Health Consumer Network's Policy and Participation Coordinator, and our other presenter this evening is Shilpa Arun, who is a member of our Consumer Advisory Group. A key contributor who can't be with us this evening, unfortunately, is Anne-Marie McNess, but she made very important contributions to this evening's presentation, and so just want to give credit to her work for what we have for you this evening. So it's a bit of a mouthful, but today our CAG is presenting our proposal for developing a model of support for peer worker facilitated relational support groups. I'm going to provide some background to the idea, what the problem is we're trying to address, and what it is we're calling for over the course of this presentation this evening. And hopefully by the end, you'll be on board that this is a really, really cool idea, and we really want to see it implemented and get some legs up underneath it. So in the past decade, both institutional and consumer-led research has really highlighted the lack of non-clinical psychosocial supports for consumers in Australia. The analysis of unmet need published in 2024 put this in really, really stark detail. And similarly, in 2025, the network published the Access Denied report. This was a consumer-led research project that really highlighted the need for more non-clinical psychosocial services that support us as whole people rather than as just a set of conditions to be treated. So when we recruited our team for our new CAG and convened our first meeting in November 2025, we really wanted to build on the work of Access Denied. And one of the things that emerged really quickly is that we didn't want to necessarily approach these topics at a really broad policy level. We were more so interested in creating something new, namely a type of non-clinical psychosocial support to specifically address persistent social isolation among consumers. Now, from the outset, it's really, really important to clarify that social isolation is not an individual choice. Rather, it's a complex outcome of environmental and social circumstances. And it's the consequence of these, which is that individuals have few social relationships, infrequent social connection, and experience distressing feelings of social loneliness. In this, social isolation can be temporary and transitory. So, for example, you might move interstate and arrive at a new location, and it might take a little while to get settled. But it can also be persistent and long-term. Now, for the purposes of our CAG, what we have been really focused on is persistent social isolation among consumers. A big component of this work that we've been doing is we've identified that it is actually the quality of and the satisfaction that we draw from our social contact with others, that is our, relationships with other people. And these are what create feelings of connectedness and belonging, or alternatively of disconnection and of loneliness. So when we think about social isolation, one of the things that's central to our work is that we treat it as a relational issue. It's not just a matter of insufficient social contact. To put it in a phrase, we can indeed be lonely in a crowd. Now, with up to 1 in 4 Australians experiencing persistent social isolation, it's a significant public health issue for the general public. Persistent social isolation is linked to poorer physical and mental health outcomes, reduced life expectancy, and increased mortality and morbidity rates. But for consumers, these risks are especially significant and especially elevated. And this is due to the potential for recursive negative reinforcement between social isolation and mental health. That is, when we are socially isolated, this can exacerbate our mental health challenges. But at the same time, when we're experiencing an intensification of our mental health challenges, that can also foster and reinforce our social isolation. With this in context, understanding social isolation as an interplay of environmental, social, and individual factors is really essential for then thinking about how to address it. So we can't address social isolation by just reducing it to a problem of individuals who lack social skills or self-confidence. So I'm now going to hand over to Shilpa, who is going to take you through some of our CAG's lived experience reflections on social isolation, encountering barriers to social inclusion, and why social inclusion is really, really important when consumers are experiencing or at risk of social isolation.
Thank you so much for that, Dia. That was really insightful. A very good evening to everyone. I'm Shilpa Arun. Moving on from what Dia was explaining about the social isolation, I would like to bring some light on the experiences of it. Social isolation affects everyone very differently. Loneliness comes in different forms, from social to family or romantic loneliness, as well as temporary or persistent loneliness. Through our work of our consumer advisory group CAG, we discussed our experiences of social isolation and identified different kinds of persistent social isolation, as well as some consequences what it can have. Different life experiences can produce social isolation in different ways. Some of the most important ones are the life transitions, such as parenthood, moving to new locations, or a career change. All of these can cause dramatic shifts in social opportunities. Likewise, the mental health challenges and or being a member of marginalized group or community can mean that social spaces that are available for most people can be unsafe, uncertain, and even unavailable. The consequences of social isolation can be especially difficult when living with mental health challenges. Social stigma and self stigma can be very disempowering and rob you of your own hope. Relationships with friends and family can become strained through a lack of support or validation. In addition, persistent social isolation can incentivize harmful coping strategies and reinforce social withdrawal as well. With less social contact and fewer relationships, our social skills can be affected, which creates additional challenges. Now, let's look into the barriers to social inclusion. Like social isolation, social inclusion is a very broad and complex idea, and it is created through structural factors like economic opportunities, geographic location, housing, marginalization, or even the legal status. When these factors create obstacles to social connection rather than opportunities, they then become barriers to social inclusion. This brings into focus the idea of social isolation as a complex circumstance rather than an individual choice. Our CAG has described a number of barriers to social inclusion that we've encountered while experiencing persistent social isolation, and we have some quotes to share that speak to these experiences. Self stigma was the most common experience. Some of the quotes are: I can feel as though I am not a valid person to be in other people's lives, or I don't want to spread my misery around. Very often, family, kin, and friends can be ill equipped to safely support us. One of the quotes relevant here is: sometimes people we want to interact with don't have the skills or the capacity to engage with us when we are actually struggling. At times, we found that it can be difficult to keep up socially. One of the quote relevant here is: we want to be involved, but momentum in a social group can outpace you. Whether it's money, family, or health, you can't keep up with what others are doing or want to do, and you get left behind. Most importantly, free and low cost local social opportunities aren't always inclusive either. One of the quotes relevant here is: it often feels as though every local program is one kind of a walking group or another. But this immediately excludes anyone for whom outgoing physical activity is either very difficult or even impossible. So now let's look into why social inclusion matters to us. It may seem very obvious that social inclusion is important. After all, meaningful social connection with other people who we enjoy the company of and who in turn enjoy ours is a vital part of the human and enjoying life. For RCAG, experiences of persistent social isolation highlighted that the opportunities for meaningful social engagement became more important. From our own experiences, we know social engagement is really important for stress relief and for sharing knowledge. It's an amazing opportunity for one's own joy. Likewise, being able to have social connection with others reminds us that we are still part of our society, that we matter and are still connected in a meaningful way. Similarly, when we are able to have a high quality social experiences, it feels like I am welcomed back to human family as myself. Our experiences led us to identify the social inclusion in its own pillar of well being and support. Very often, therapy enables us to cope with the world and helps us to live as ourselves, but it's meaningful social engagement that gives us the desire to live in the world. These experiences have demonstrated to us the importance of safe, accessible, and welcoming social connection as being essential to our recovery, our sense of belonging, and our hope for the future. Now, I would like to discuss about how consumer relational supports are missing in the system. If you're a consumer who is experiencing or is at risk of persistent social isolation, well, what are your options for support within our current mental health system? Broadly, we all know that the public and the private mental health sectors covers only acute, diagnostic, medicinal, carceral, and inpatient clinical services. Meanwhile, non transactional community mental health supports tend to be divided between social activity and group therapy programs. But there's a big issue here. On one hand, even when there are accessible social activity groups, they can actually be socially unsafe or unwelcoming or even ill equipped to support all the consumers. On the other hand, therapeutic or recovery focused groups supports are not necessarily designed to provide space for ordinary social connections and engagement. It's a middle ground for consumers is therefore missing a safe, accessible, and non clinical relational supports. As we all can see, there is a big need for a form of non clinical psychosocial support that is focused on nurturing a consumer's confidence and a connection with others at a time when these may be at their lowest. And this is the key and a central idea of our proposal. Over to you, Dia, to go through the rest of the presentation. Thank you.
And thank you very much for that, Shilpa. So, with all of that being prefaced, what we are envisioning here is something new and complex, but we also think it's really rich with potential. Specifically, we are proposing the co-produced development of peer worker facilitated relational support groups. Now, provisionally, we have offered a definition of these as being programs and or groups that support consumers who are experiencing or at risk of persistent social isolation to access safe, non-clinical spaces for the purposes of social connection and mutual sharing that builds relational skills and confidence. We think relational supports ought to be considered as a distinct kind of non-clinical psychosocial support to be included alongside practical, task-oriented, and recovery-focused psychosocial services and supports. Now, essential to the idea of this type of support is creating and maintaining a social space that is accessible, free of stigma, welcoming and safe for consumers. And this is why we see such a vital role for peer workers, because keeping this type of group going takes forward planning and really careful stewardship. The role of peer workers, as we see it, will be to promote the ethos and habits of the group and also to act as check-in points and mediators for participants. Now, the overarching goal of this kind of support is to provide consumers with safe avenues for social connection that increases their social contact with others, expands their local social connections, reduces feelings of social loneliness, whilst also fostering a sense of belonging and hope. And we see this support as being especially impactful for consumers who are going through experiences that are particularly isolating. So one of the really obvious examples here is when you're going through substance use recovery, often a part of that process can be having to disconnect from friends groups and family groups that you would otherwise rely on for social connection. And social isolation can be a very lonely, difficult experience that can increase the challenge of going through substance use recovery. We also see potential here for consumers who live with schizophrenia and or psychosis as well, where other activity groups and options may not be adequately equipped to support them when they're going through a rough time and needing social connection. So to take this from the vision to implementation is a really, really, really big challenge, and we understand that completely for our CAG. However, it doesn't mean we can't get the ball rolling. So our CAG project, therefore, is to develop a position paper that advocates for a dedicated co-production process between peer workers and consumers to develop a peer worker facilitated relational support groups model of support. We want to have a model of support that is co-produced because this will ensure that all the sort of principles and considerations of duty of care, operational guidance, and risk management are really carefully considered and addressed. In addition to this, a transparent and robust co-production process will give the model of support a level of integrity and trust that is more likely to inspire buy-in from stakeholders across government and the community sector. The outcome that we envision for this co-production process would be the creation of a model of support that is ready for distribution to stakeholders and which can be used as the foundation point for piloting programs across state and territory jurisdictions throughout Australia. So where to from here? The focus of our CAG work going forward will be to bring together all the necessary evidence and expertise required to develop a strong position paper that outlines the need for this intervention, that articulates the core of the model of support's theory of change and why having a serious and dedicated co-production is the next necessary step to carry this project forward. We agree that it's an ambitious project, but we're really, really excited about it, and we hope that after this presentation, everyone else is as well. So thank you so much, everyone, for all your time and attention this evening. And I'll now hand you back to our MC, Stephanie.
Thank you so much, Dia and Shilpa. I think it's incredibly validating to see that there is a growing recognition of that social isolation is not a personal failing, it's actually a public health issue. And so I'm really glad to hear about the impact of relational supports and non-clinical spaces that can restore connection, dignity, and belonging. Unfortunately, that is all we have time for today. The next consumer-led conversation that we are hosting will be on Tuesday, the 28th of April from 5 to 6 p.m. Australian Eastern Daylight Savings Time. You can use the QR code on the screen to register. We'll be hearing from the WA, Victorian, and Tasmanian consumer advisory groups. We also ask that if you would like, you can complete the evaluation form that will appear on your screen when the webinar ends, and we'll also email it to you later this week. As this is a new series for us, feedback is vital in ensuring that we are making these conversations a great success. So finally, the recording for today will be available on our website, nmhca.org.au. And for those of you who are who are mental health consumers, I encourage you to join your local peak body, and if you haven't already. Details for each Peak Body are also on our website. And to hear more about the future of consumer-led conversations, please sign up to our Alliance mailing list, which is also available on the website, or follow us on social media. Again, thank you to all our panelists for their time this evening and for everyone who has joined us today. Bye for now, and I guess I'll see you later.